Okay, I am going to get started and people will be rolling in. Hello, I am Gina Asaf, she, her, a co-founder and co-lead of PLRC, patient with long COVID since March, April of 2020. I'm olive brown-skinned woman wearing a turquoise earring which look white and wearing a dark blue sweater with purplish pink lipstick. Passing it off to the other speakers to introduce themselves before we begin the presentation portion. Hannah?
Hi everyone, my name's Hannah Davis. I'm a non-binary person with shoulder-length dark brown hair. I'm wearing a white sweatshirt with emojis on it, and I've had long COVID since 2020. Passing it over to Letitia.
Hi everyone, I'm Leticia Suarez. My pronouns are she, her. I got sick in April 2020 and I've been with PLRC since 2021 as a member of the leadership team for a little bit over a year. I have light brown skin, shoulder length, dark brown wavy hair. I have dark brown eyes and I'm wearing transparent glasses and a dark blue top. I'm going to pass it on to Lisa.
Thank you. Hi, everyone. My name is Lisa McCorkle. I'm another co-founder and co-lead of Patient-Led Research Collaborative. I use she, her pronouns. I've had long COVID since March 14th of 2020, and I am a white woman with brown hair wearing a turquoise shirt. And I will pass it back to Gina to get us started.
Thank you for joining us today for our first end of year webinar. We have over 300 registered attendees, which is exciting. We're excited to share our work over the past few years and what's ahead for PLRC. Before I start, a few housekeeping items. Click on the Q&A button at the bottom of your screen to ask questions. And we will answer as many questions as possible within the allotted Q&A time. We will have 15 minutes at the end of the presentation to go through them. If you need captions, click on the Show Captions button at the bottom of your screen. You can drag the box where the captions appear and position them anywhere in the screen. Lastly, we will share the recording and slides after the webinar. First, let me go over the agenda for today's presentation. We will be covering who we are, an overview of PLRC, and then we're going to go into our work, organized into several subsections: research, advocacy, patient engagement, medical education, and we'll go a bit into impact and recognition, and then we'll go over what's ahead for us, and finally have the Q&A portion. The presentation portion will be an hour, and we will have 15 minutes for the Q&A portion after that. Okay, so let's get started. Who is PLRC? This is the section I'll be going over, which is about PLRC, our team, vision and mission, our values, talk a bit about our valued partners and collaborators, and our funding. So who is PLRC? We are an international group of people with long COVID and infection-associated chronic conditions who come from a diverse range of professional backgrounds and interdisciplinary skills across science, technology, policy, and media. We met and formally formed in April of 2020 in Body Politic support group. We were looking for answers on what we were experiencing and found each other and put out the first research, which we'll be talking about further in the presentation. And we aim to represent people worldwide with long COVID through our participatory work on long COVID research, medical education, advocacy, and other work through our lived experiences and our interdisciplinary skill sets. Here on the next slide, we have a list of our current team. We have a flat leadership structure where 4 leads currently co-lead the team. You heard from them at the beginning of the presentation, and each of them will also be presenting today. We have had other leadership members who continue to volunteer but step down from leadership work. We have a few paid staff members who are part-time, and the larger group who are volunteers make up the rest of the team. Some of these volunteers are also sometimes paid as part of engagement on specific projects. So I'm going to go over our vision and mission, which help guide us, which we recently updated with a participatory process by our team. So we envision a world which all people with long COVID and associated conditions receive high quality care that improves their quality of life, and where research into long COVID and associated conditions is equitable, patient-centered, efficient, and transformative. And so our mission is to improve the breadth, depth, and speed of global research into long COVID and associated conditions, and to advocate for policies that improve the quality of life for long COVID patients worldwide. Our values are also important to us, and we operate and lead with these in mind. Disability justice, as defined by Sinzin Village, is foundational to and guides our work and organizational culture. Access, we work towards supporting solutions for problems that are urgent and require fast-paced responses, but it is sometimes in direct conflict with managing a chronic energy-limiting illness. To support ourselves, we promote a collaborative work culture that prioritizes well-being and is inclusive of access needs, and we give people grace to be productive as they're able to do so and recognize each person's contributions. We are patient-centered and led. We prioritize lived experience of people with the conditions and lead by example. We're evidence-based and data-driven. We are committed to evidence-based advocacy, and we conduct our own research and support scientific research in order to gain high-quality data to support impactful end results, such as policy changes, treatments, and clinical practices. We work with many other long COVID and infection-associated chronic conditions groups, and have had the opportunity to collaborate on several projects and initiatives with several of them. Listed here are a few of these orgs, and there are several more, and we wanted to acknowledge and say we appreciate all the work everyone is doing in this space. We also collaborated with research and clinical care and tech organizations in the health tech space, such as the ones we listed here, and we have ongoing projects with a few of these currently as well. We're also part of coalitions and groups, which has been crucial, especially for advocacy. We're on the steering committee of the Long COVID Alliance, and we're a co-founder, and we're on the steering committee of the Infection-Associated Chronic Conditions Initiative. Are a member of the Disability Economic Justice Collaborative, which is run by the Century Foundation, and are a member of an ad hoc group of other infection-associated chronic conditions and illnesses. It is crucial to be in collaboration with other long COVID groups, other infection-associated chronic conditions, and other disabilities to achieve what we're fighting for. Over the past few years, our funding has fluctuated, averaging about $500 to $600K annually, and this doesn't account for the early years, and much of our work was all done volunteer and unpaid. And we've been fortunate to receive dedicated funding to support our work since the end of 2021. And you can see from the funding sources chart that nearly 50% of our funding to date has come from the Balvi Philanthropic Fund. And it's important to note that this does not include the PLRF, which was the Patient-Led Research Fund, where Balvi allocated funds directly to other organizations. The Chan Zuckerberg Initiative, CZI, has also been a key supporter, providing essential operational funding, which has been invaluable in keeping our day-to-day work running. The Silver Giving Foundation, accounting for about 21% of our funding, has focused primarily on supporting our advocacy efforts. In addition, we've received project-specific funding, such as for our work with N3C, and smaller contributions from organizations like PCORI, CMSS, and a few others. We're also grateful for our individual contributions from individual contributors whose support has made meaningful difference as well. And then if you look at our funding allocation chart, you can see that most of our funding has been dedicated to research projects. And second would be our advocacy work, and then also medical education. Some of these funds have also supported science communication initiatives and operational expenses and covering fees for our fiscal sponsor. And then, as many of you know, the financial landscape for COVID-related work is becoming increasingly challenging, with much of the dedicated funding running out. While we're incredibly proud of all what we've accomplished with this relatively modest resources, we are facing, funding challenges ourselves. By sharing our work that we've done and our plan for the future, we hope to inspire new funding opportunities to continue and expand our impact. Thank you for listening, and I'll pass it off to Hannah Davis to go over our work today, where she will dive into the research. Thank you.
Thank you, Gina. Hello, everyone. I'm honored to talk about the overview of our research work in particular today. PLRC has put out over 40 publications to date in the less than 5 years we've been around. And these reports and papers have increased over the years. So we've put out 35 papers and reports. 11 of those have been led exclusively by PLRC. 24 have been collaborations with other people. And we've also done 4 book chapters written by PLRC members, as well as policy reports and other documents. PLRC has over 6,800 citations of PLRC work, which is fairly incredible from an academic standpoint. So I'd like to go over a few of the highlights from our research. And we're going to go back to the very beginning. So PLRC put out the first ever report on long COVID on May 11th, 2020. This was well before most people knew that COVID was causing these long-term conditions. We basically set the stage for how to conduct long COVID patient-led research, as well as increase the number of symptoms that were asked about. And the paper was cited in the announcement of the $1 billion in NIH funding and in international press. It also helped get the WHO and CDC involved in our work and led to Ed Yong's first piece in June 2020. Our work has crucially corrected several misconceptions about long COVID. Sometimes it's helpful to think of this space as continuing to correct just wrong ideas people have about this condition or what can happen with COVID. And some of the early work in particular helped correct things that were fairly well thought of as true. People were saying that COVID recovery happened in 2 weeks. We showed, some people never recover. Early on, it was thought that COVID only caused respiratory symptoms, but we helped show that COVID causes symptoms across all organ systems, including neuro and cardiovascular issues. A lot of people at the time thought that everyone made antibodies and you could tell if you had COVID by an antibody test, but we helped communicate that a large percent of people don't make antibodies at all or serovert, meaning they lose them quickly, even in the first couple weeks, and that's disproportionately likely in women and children. At the time, a lot of long COVID clinics and doctors were requiring a PCR test to get medical care, and we helped communicate that PCR tests had high false negative rates and were inaccessible to many people, especially in the first waivers. Later on in the pandemic, we helped show that many people who were sick with long COVID at 3 months did not recover by 2 years. The narrative that children can't get long COVID was something we focused on, showing that children can and do get long COVID at meaningful rates. A lot of people thought that exercise was a treatment, where we helped communicate that people with ME/CFS from COVID and post-exertional malaise are harmed by exercise, that there are no treatments and there are no FDA-approved treatments, but that there are symptom management treatments available, like ivabradine and beta blockers, etc. And often people thought that long COVID was the continuation of acute COVID symptoms, where we helped show that long COVID doesn't necessarily happen immediately during the acute infection, but can start in the weeks to months later after infection. Our first major research publication was released in December 2020. This was an enormous project. It's difficult to communicate just how much effort went into this. All volunteer, with many collaborations from international groups. We ended up being able to collect 3,700 respondents from 56 countries. We translated the survey into 9 different languages and circulated it among international groups. And this characterized long COVID, the frequency of different symptoms, and also the trajectory over the first 7 months of illness, which remains one of the more unique data sets in the long COVID space. And this preprint has been cited over 5,000 times. It has 88 citations from policy documents in governments all across the world. And it's the fourth most cited paper among long COVID papers ever published, 800 times more citations than other research in the field. Our review that we put out in January 2023 similarly got a lot of attention and influence. This was a collaboration with a renowned research institution, which is Scripps Research. And this was the first summary of the breadth of biomedical research that was out. I mean, long COVID research has been coming out since 2020, and the distribution of that knowledge has been really difficult. And so this really aggregated a lot of the biomedical findings across all organ systems, as well as suggesting potential therapeutic inventions. This is the kind of thing that could really have only have been done by patients because we were so aware of the patterns of this community before the general public were and before medical providers were. This one also has had several thousand citations and has been downloaded 1.54 million times, predominantly by medical providers and researchers. And it's number 56 of 27.4 million papers across all fields on altmetric. Eric Topol, who we collaborated on this with, said that he had written hundreds of articles before, but had never seen an outline like this. And again, that could have only been done because we were patients. We've also done research into difficult subject areas. Everyone knows, I think, long COVID has been psychologized quite a bit. We worked with Yohai Rem, who is himself a long COVID patient, and psychiatrist to look at the factors associated with different mental health conditions in long COVID. And we were able to do this from a patient prioritized lens, showing that things like medical provider stigma and negative experiences with medical providers and family and friends, etc., can contribute to these issues. Next slide, please. We've also looked at a lot of the areas that patients care about that have not been studied as much. So we put out a paper, a review of female reproductive health impacts of long COVID. I think many people who menstruate know that the long COVID changes with the cycle and that it makes other associated conditions worse. And this was one of the first papers to actually highlight those connections. Our first qualitative research paper was on returning to work with long COVID. So this was using the PLRC survey to systemically analyze the return to work experiences of 510 people with long COVID. And we wanted to apply our data toward support for people who were trying to go back to work with long COVID and highlight what the issues and challenges particularly were. One of our other cool papers is a case series documenting 13 case series of people with long COVID who took an extended course of Paxlovid and what the impact of symptoms were on those. And this really demonstrates the importance of gathering and documenting anecdotal evidence from the patient community. And this will be out soon in Communications Medicine. We also put out recently a preprint looking at multi-method phenotyping of long COVID patients, also using our symptom survey data. So this was looking at 162 symptoms in over 6,000 patients, applying 3 different machine learning methods, which is an example of the advanced analytical skills that PLRC has. We found that over the 3 types of machine learning methods, we weren't able to find recurrent clusters. And this was research that was directly in response to needs and challenges of kind of trying to understand and characterize long COVID phenotypes, and pointed to the likely fact that symptoms aren't the right data set to create phenotypes on, and we need to be working toward different markers of phenotyping. More recently, we put out a paper on reinfections, which had been prioritized by the long COVID community as a very important topic. This was an international survey with almost 3,400 patients, and found that COVID reinfections were associated with higher odds of reporting long COVID generally, um, post-exertional malaise, severe fatigue, functional limitation, and 50 plus other long COVID symptoms. And this again came from the priorities of the long COVID community. PLRC is also part of an international team based in Brazil, between the Brazil, US, and the UK, which is investigating the prevalence of long COVID and the healthcare needs and experiences of people with long COVID. And this collaboration included the production of educational videos on long COVID and the patient experience to be used for medical education. We've also worked in collaboration with Long COVID India to lead an investigation on the experiences of people across the country navigating healthcare access. PLRC interviewed a diverse group of people in India, including doctors, allied healthcare professionals, and long COVID patients in both urban and rural areas. And this report will be out soon as well. Earlier this year in August, we put out a second review with major researchers, including Ziad Ali, Professor Wasaki, and Eric Topol, looking at the roadmaps for research and policy for the future of long COVID. Talked about how policy needs included prevention and support, access, quality, and equity of care, professional education and training, public health communications, and coordinated interdisciplinary research. And the research roadmap included looking at biological mechanisms, diagnostics, clinical trials, the clinical course of the disease, and care delivery and health systems research. We're also working a lot right now in particular on improving the design of clinical trials and pushing for clinical trials, as well as looking at drug repurposing. We've published several op-ed articles on clinical trials and drug repurposing. Our PLRF funding of UCSF was for a monoclonal antibody clinical trial. We've done patient engagement on both selecting the drug choice and strengthening the design of multiple trials that are out right now. We've done a lot of presentations and given feedback to groups like Recover TLC, as well as keeping an ongoing updated list of repurposed drugs to trial. We've worked closely with the FDA PureID group to participate in, which is a drug repurposing collaborative, to make a patient survey of effective treatments, which will be able to be analyzed and given to the FDA as input. And we're also part of a clinical trial think tank group alongside CureID and have monthly meetings with teams running some of the best clinical trials worldwide. We've additionally put out a lot of pieces on just commentary and perspective pieces on research itself, which includes both things like patient-led research as a field and why it's important to include patients in research, and what patient priorities in research look like, especially in the long COVID space. And then we put out, as Gina mentioned earlier, we had an additional 5 million to redistribute from Balvi to put toward a biomedical research fund, which is what we had pitched. And so we were we put together a panel of entirely patient researchers who were educated in or were passionate about the different updates in the long COVID and associated chronic conditions field. So these projects were all chosen by entirely by a panel of patient researchers, and this funded 10 research projects, one clinical trial, next slide, please. One clinical trial, 2 studies on the immunology of long COVID, including one on T-cell exhaustion, 1 microbiome study, 1 on the physiology of post-exertional malaise, which led to a possible biomarker and was one of the best papers of this year. 1 study on sleep dysfunction mechanisms, which does imaging and other testing of the brain during sleep. 1 study on pushing forward the microclot testing and research. 1 on using AI for repurposed drug identification. 1 on surgical management of long COVID of ME/CFS, which was doing additional research on surgeries that were already being done to see in the neck to see if they would change ME/CFS symptoms, and then 1 multi-systemic analysis. And then we've also done a wide range of other collaborations, too many to fit here, but this includes a diverse group of different types of research projects, from For You and Me to evaluating measurements of episodic disability, to looking at the National Survey of Health and Disability data. We're working with Visible to look at longitudinal reinfections data, and we've also done a lot of work with the National Clinical Cohort Collaborative, which is a group specifically looking at long COVID through an EHR, electronic health record lens. And this is truly not everything we've done. I think what we'd like to communicate is just how our research has been impactful, because we've been so kind of ahead of the general population in knowing what is happening in the long COVID community, knowing what questions to answer. We've been able to have a pretty high impact in the field. We've been able to adapt as the pandemic has progressed and the knowledge of long COVID and community needs have changed, which reflects our organizational flexibility. We've prioritized some of the most significant topics to patients to research, and through our own research, both through our own researcher and collaborating with other researchers, and by funding other researchers. And also, as we have been involved in other studies, we're ensuring that significant areas are incorporated into study design and therefore strengthening the research as a whole. So I'm going to turn it over to Lisa now to talk about policy and advocacy.
Thank you, Hannah. Hi, everyone. So I'll be covering some of the highlights of our policy and advocacy work over the last 4.5, almost 5 years now. So with any chronic illness, there are a wide range of policy areas that impact people living with the condition. So while much of our work has focused on advocacy for funding and research, we've also done work on prevention, definitions, care, education, public health surveillance, disability, safety net and support, and labor and employment. And we've put together policy recommendations that cover all or most of these areas, including this Medscape op-ed published last year, which you can see on the slide. And we're really seen as a trusted source of information across governments, have especially provided input to US agencies, including NIH, HHS, FDA, CDC, AHRQ, SAMHSA, and Department of Labor, as well as across Congress and even some local and state jurisdictions. So I'll cover some of the examples of these now. So we've done a lot of work on trying to get the US government to fund long COVID research, as well as other areas of their response. Since 2021, we've written testimony regarding budget requests. Last December, we coordinated a letter to President Biden asking him to prioritize long COVID and other infection-associated chronic conditions in his FY25 budget request. And this was signed by prominent researchers, public health practitioners, clinicians, and thousands of other organizations and individuals. This year for FY25 appropriations, we advocated in partnership with Long COVID Campaign and Long COVID Moonshot for $1 billion in NIH research funding, $200 million to ARPA-H, $20 million to the Office of Long COVID Research and Practice, and then adding long COVID to the Department of Defense CDMRP, and also adding some report language into the appropriations bill. And we were able to get the support of key senators in those efforts. We're still waiting to see what actually ends up passing, but in the markup in the Senate, it did have long COVID added as a topic area to the Department of Defense CDMRP. Congress was directing ARPA-H to study long COVID, so no line item, but at least discussed it. There was continued funding for ARC to continue their long COVID care network, and then there was also report language referencing long COVID throughout the markup bill. So we'll see what ends up passing, and we plan to continue to do this type of appropriations work next year, trying to influence the FY26 government budget. In October of 2023, last year, Dr. Michael Peluso at UCSF and I published a comment in Nature that called for a moonshot for long COVID, which we defined as at least $1 billion a year in sustained research funding to the NIH. And fast forward to August of this year, and Senator Sanders introduced a bill doing just that, plus adding on funding for other areas of the response like clinician education and surveillance. And then a companion bill was introduced in the House of Representatives by Representatives Omar and Presley. So we don't expect action on this bill this Congress, but we do expect that the bill will be introduced next session with some potential changes to react to developments in the long COVID space. We regularly provide recommendations on how to improve long COVID research, bringing attention to community experiences and key pitfalls. We've talked about some of those already. Several of our members have been involved as patient reps in the Recover Initiative since July 2021, which is right when it started. And then in November of 2021, we issued an open letter regarding Recover, calling for meaningful patient engagement and more inclusion of post-viral illness experts. This was done in partnership with some of our key collaborators like Body Politic. In August of 2022, we provided recommendations for the U.S. National Research Action Plan. That was in partnership with other members of the Long COVID Strategy Circle, and some of those recs were included in the final plan. We also had a few members participate in the FDA's patient-focused drug development meeting for long COVID, and then we've submitted recommendations for NIAID's strategic plan as well as for the upcoming Recover TLC. And we had key roles in presenting that and organizing the agenda for the Recover TLC workshop. So these are some of our more public examples of research advocacy, but we also advocate for better research whenever we are patient reps on any study or are writing articles about what's important to patients. On the prevention side of things, we've provided press quotes when CDC or state guidance for isolation policies or COVID mitigation has changed. We've written op-eds like Julia Moore-Vogel and Allison Cohen's great article in the SAC-B after the California isolation recommendation was announced. We've met with the CDC, with other disability organizations, though those meetings were not productive and we were not very meaningfully engaged in that. We regularly sign on to letters pushing for better mitigation measures, including clean air, and we advocate for masking in healthcare, in Recover studies, and more. So this is a side of advocacy we've not really seen progress on. We've regularly gotten pushback on. That makes it all the more important for us to speak out on. Oh, I clicked on the link. There we go. Okay. We've given feedback on several long COVID definitions and guidelines starting in 2020. And not all of our recommendations are taken, but we have been able to substantially improve many of these to ensure they're more representative of the patient experience. We are part of focus groups and presented at a workshop for the NASM definition. We contributed to the World Health Organization's clinical case definition. And in partnership with Body Politic, we provided feedback on CDC web pages right early on when they first got long COVID pages, and on NICE guidelines as well. On another side of research, we've advocated for increased prevalence research, especially at the beginning of the pandemic when long COVID wasn't being studied. So we advocated to add questions about long COVID to the household pulse survey, as well as other national surveys, and gave recommendations on wording to best capture the population. While not perfect by any means, this has been key for demonstrating how widespread long COVID is. And the household pulse survey, as well as the national health interview survey, is likely at risk in the next administration. So that's a key thing to be aware of and advocate for those to continue. In April of 2021, we supported the implementation of the post-COVID condition ICD code, UO9.9. And we also proposed an ICD code ourselves for post-exertional malaise. Unfortunately, this was turned down twice due to lack of consensus, and we've lacked the capacity to continue this effort, but it can always be picked back up again. We've also provided recommendations across disability, labor, and safety net policy, including through policy briefs with CLASP and Urban Institute. We've participated in efforts with other disability organizations on improving how the U.S. government measures disability, and presented at webinars, including ones hosted by the National Academy of Social Insurance, and actually just this morning at NOSCR, which represents Social Security claimants representatives. We gave feedback on a letter from Senator Kaine to the Social Security Administration, which asked for a listing or ruling for long COVID, as well as better data collection practices, and have supported legislation that covers all of these areas, like the Long COVID Support Act, Treat Long COVID Act, as well as disability reform legislation. We've had the opportunity to have a lot of speaking engagements, which has been great. I'm highlighting some of the more notable ones here, including testifying to Congress twice, one in April 2021 and once in July 2022. We've presented to the White House several times, presented in a roundtable hosted by Representative Presley, and have presented at several National Academies events for long COVID, infection-associated chronic illness, and even one on building new public access policies. So overall in our advocacy, we use evidence, including our own and the community's lived experience, to advocate for policies that will improve research and patients' quality of life. We are a resource to policymakers while also holding people in power accountable. So we have positive working relationships with key leaders, but we're also not afraid to critique or put public pressure when needed. We collaborate with and learn from other organizations across long COVID, infection-associated chronic conditions, and disability fields. And we are really deliberate and thoughtful in what we choose to take on. And now it is my pleasure to turn it over to Leticia.
Thank you so much, Lisa. I'm going to be talking about giving an overview of the patient engagement work that PLRC does. So we have, next slide, please. We have three major focus areas of patient engagement: the patient-led research scorecards, our patient-generated hypothesis journal, and patient engagement on studies led by our collaborators in academia and in industry. And through this work, we have been able to experience firsthand and show that research with meaningful patient engagement versus research that has not patient engagement at all, or it is not meaningful, has been more transparent, less biased, more effective, collaborative, and relevant. Next slide, please. So what do we mean exactly when we say meaningful patient engagement, and how do we measure that in, let's say, a patient-researcher collaboration? So to address these points, PLRC, in collaboration with the Council of Medical Specialty Societies, developed and successfully launched the patient-led engagement scorecard and a playbook for evaluating and for scoring patient engagement. These scorecards, they focus on specific areas to advance patient engagement, such as integration into the research process itself, governance, shared decision-making, and patient participation burden. Next, please. Thank you. In action, these scorecards have been used as a guideline to implement and evaluate meaningful patient participation in biomedical research studies, including clinical trials like reverse long COVID clinical trial. And they also have been incorporated in grant funding opportunities as a requirement for applicants to use scorecards to evaluate their proposed patient engagement, like it was recently proposed by the Catalyst grant through the Rehabilitation Science Research Network for COVID at the University of Toronto. So these scorecards have also been the basis of many recommendations provided to government agencies, funders, patient groups, and researchers. Our second focus, centering on patient engagement, is the Hypothesis Journal, which is a project that was funded by Balvi. And the goal of the journal is to feature articles that present research questions and hypotheses developed by patients to facilitate bringing ideas and lived experience of patients to researchers and funders. And in order to select the papers that were going to go into the journal and to work with the authors, who are all patients, throughout the publication process, PLRC put together an editorial team that was interdisciplinary and formed by an international group of people with long COVID and infection-associated chronic conditions. And with the funding received, we were able to publish 2 issues of the journal, which are freely available to read on our website. Next one. And finally, we have been playing a pivotal role in long COVID research with our work as patient representatives, like Hannah and Lisa mentioned that several times. Where we have offered our expertise in dozens of research projects to date. And some outstanding examples of our work as patient reps include, we assigned 2 patient representatives to projects that were funded by the Patient-Led Research Fund. We are representatives in Recover and Recover TLC at AAPMNR, and at CORE at Mount Sinai. And we also have been working alongside multiple clinical trials like reverse long COVID, baricitinib trial, BioV, bezisterim trial, and antihistamine trial. And we have also reps at the Long COVID Care Network of the Agency for Healthcare Research and Quality. And this work that we do as patient representatives moving research forward will continue to be at the core of what PLRC does. And now I'm moving to give you an overview of our work with medical education. Next, please. So we have had dozens of speaking engagements in person and virtually, including multiple talks through Project ECHO, universities, med schools, long COVID clinics, the WHO and NIH conferences, and have participated in some of the most high-profile medical and academic conferences like the Keystone Symposium. And in general, our work with medical advocacy has been helping change the baseline medical care people with long COVID receive, just by increasing awareness, validation, and removal of reliance on positive tests, which has been something that people with long COVID have encountered as a barrier to access diagnosis and care. Next, please. In partnership with ME Action, we developed a fully referenced pacing guide. It's a pacing and management guide for clinicians and it's for long COVID and ME/CFS. And so also with ME Action, we have produced a series of 4 educational videos on PEM and pacing in collaboration with long COVID patient and advocate, Shamir Sweeney. So altogether, our work has had major impact in advancing research, care, and policy for long COVID. And as a result of our efforts, next please. As a result of our efforts, we have received significant recognition. Like early on, Dr. Tedros, director of the WHO, for example, he said that patient-led research and activism were writing the first textbook on long COVID, and he was referring to the report that we put out that year. Dr. Ziad Al-Ali, one of the most prominent long COVID researchers, said that when history of medicine is written, PLRC is going to be seen as an essential piece that galvanized awareness that long COVID exists. And we were also recognized by AAPMNR in 2021 with the Distinguished Service Award. And by having our co-founders, Lisa McCorkle and Hannah Davis, be recognized in 2 major lists in 2022, which we are super proud of them. And more recently, just this past month, PLRC was listed by the New York Times as a designated nonprofit to donate. So we are very honored by all of this recognition. Next slide, please. And all of this mainstream recognition across the board and how we have been noticed from mainstream media outlets highlighting that the NIH director cited our work to politicians such as Representative Debbie Dingell, who mentioned that she was very impressed by the ability of patients to self-organize and quickly get results into the medical literature. And our work has also been recognized by prominent scientists and allies in the field, like Dr. Trino, who said that we move orders of magnitude faster than traditional modes of research, which were, all of these are just pieces of recognition that we are very proud and we are very thankful for. Next, please. And I'm going to hand it over to Gina now, who's going to present what's ahead of us. Thank you.
Hello, it's Gina again, back to talk to you about what's ahead for PLRC, which is divided into 2 sections. I'll be first going over our strategic plan and goals that we have planned for this future and near future, and Lisa will discuss how to support PLRC. So where are we in the field of long COVID? There are positive things like significant biological research release. Awareness of long COVID has improved among public health providers and policymakers. However, there's still limited clinical trials and no FDA-approved drugs today for long COVID. Medical knowledge and education efforts exist, but they're insufficient. Based on that, a few priority needs still exist where patient groups like us can make a large impact. For example, distribution of research and medical education, biomarkers and more clinical trials, advocating for that, increased representation of most affected populations. And on the advocacy front, focusing on where we can make an impact, being nimble and continuing to fight for more funding and coordination across all areas of government and better policies that improve patients' quality of life. The importance of patient-led research in general and the work we do is critical. And I love this quote from Dr. Eric Topol emphasizing this point. He said the exemplar of patient researchers is PLRC, who continue to make extraordinary contributions to enhance our understanding of the condition and guidance towards desperately needed treatments. Given all of that, I'll be talking about our strategic plan for the upcoming near future, which includes research with a focus on clinical trials, advocacy work, relationship and collaboration with marginalized communities, and our general operations. First, let's take a moment to walk through our strategic priorities in research and medical education for the coming year. At the heart of our work is the principle of patient leadership and involvement. And on that front, we are committed to advancing patient-engaged long COVID research in low and middle-income countries, where there still is big gaps in long COVID research compared to other countries. Based on the results of the Brazil study that Hannah talked about briefly, a key focus of the team that they prioritized was leveraging community health workers to improve patient outcomes. And this is an area we are trying to pursue. To support and scale our research efforts, we're also improving research, or we want to improve research infrastructure. By establishing a patient registry with Care Evolution, this will serve as a hub connecting patients and trialists for clinical trials. And beyond recruitment, the registry will enable us to study long COVID development, relapse, and remission patterns, and give us deeper insights into the disease trajectory. Another area we would like to tackle with our research is analysis and or improving the PLRC data curation, archival, and coding repositories to share our data sets. We also have made progress and are currently working on the analysis and publication of reinfections longitudinal study with Visible, and this is all currently volunteer, and we would like to ideally get funding for that. We would like to also build and implement a strategy, previous slide, build and implement a strategy to involve HIV and AIDS researchers in the field of long COVID, given their strong work in an area that was that they had worked on and we could learn a lot from. And then also, we would love to disseminate research for medical education. And finally, we would like to seek funding and implement a second patient-led research fund, given the success of the first one, but we would at least require, 2 million and preferably 5 million to be able to do this work. Second big area in research is advancing clinical trials. As part of our strategic plan to advance clinical trials, we're focusing on generating actionable insights and tools to improve how long COVID treatments are studied and developed. A potential area of work we would like to prioritize with funding is analyzing a data set provided by the FDA Cure ID program. This data set contains information about treatments that have worked, and just as importantly, haven't worked for long COVID patients. And by understanding patterns in this data, we can identify promising therapeutic approaches and avoid repeating strategies that lack effectiveness. We would also love to create and distribute 2 practical guides to support those conducting and planning clinical trials. The first guide would focus on the clinical trial endpoints landscape and provide an overview of an existing endpoints used in long COVID research and offer recommendation for improvements. The second guide would address the repurposed drug landscape, and it would highlight existing drugs with potential for treating long COVID, along with recommendations on which to prioritize for clinical trials. On the advocacy front, despite the changing landscape with the new administration, we plan to continue to do what we've been doing, but we will assess our strategies as we go, being nimble and deliberate. We plan to continue to advocate for increased funding for research, care, awareness, and more, as well as continue our efforts to improve and implement better policies that impact people with long COVID across policy areas. We may be up against a lot these next 4 years, and we'll need the community's help in mobilizing for certain actions. We also hope to continue to inform agencies on how to best respond to the crises, responding to emerging public health needs related to long COVID and related infection-associated chronic conditions. We also want to support other orgs in expanding their advocacy efforts and to contextualize research findings into clear, concise, and actionable messaging for public use. And part of our strategic goal is to strengthen our partnerships with marginalized groups, especially racial and ethnic minorities, both in the US and globally. We know COVID has had disproportionate effects on marginalized populations, especially among racial and ethnic minorities. So evaluating the impact of long COVID and concerns of these populations is crucial. And we want to do more there. We're working to deepening the relationships with these communities and bring their voices into our work by doing more, such as inviting more diverse members to join PLRC and collaborate on projects with us. to make these partnerships meaningful and sustainable, we're also seeking funding to support this work and seek funding together with organizations that represent marginalized groups and communities. And on the operation fronts, on the strategic side, we're working to ensure that our operations and team are set up to support our growing impact, which includes updating our operational structures, streamlining general operation systems, and seeking funding for sustained support of general operations. We're also looking to actively improve and prioritize our team growth by improving our volunteer management system, providing training on topics like disability justice and health equity, and hiring for critical roles in operations, advocacy, and leadership. And so by strengthening up both our systems and our team, we're building a solid foundation for hopefully sustained success. Thank you for listening, and I'm going to pass it off to Lisa to talk about how to support PLRC.
Thanks, Gina. So first, just a reminder to all attendees to feel free to add your questions to the Q&A box, and we will get to the Q&A very soon. But first, let's touch on how you can support this work. So first, we are hiring for 2 new positions, hopefully full-time, but there's some flexibility in hours. One is a fundraising and operations manager, and the other is a partnerships and advocacy coordinator. If one of the team can put a link in the chat to the job descriptions and application, and we'll be posting that online in the next few days. And then we also always accept volunteers, although we accept and onboard volunteers on a variable basis due to capacity largely. So it may take a while for us to get back to you, but especially if you have expertise in clinical trials, policy advocacy, or fundraising, please fill out the interest form. We also wanted to highlight that we offer a range of advisory services that are designed to support researchers, healthcare providers, and other stakeholders in developing more effective and efficient patient-centered outcomes. So these services can really vary in length and type of relationship based on the needs of the people seeking these services. So it can be short-term consulting, it can be long-term collaborative projects, and it's really across a wide range of our work, from consulting on research, providing input on clinical guidelines, doing speaking engagements and medical education, evaluating patient engagement, and doing patient recruitment. So more information can be found on our website, which we'll put a link to that in the chat as well, or by emailing us. And lastly, we are at a critical juncture in terms of our financial sustainability, and we really need your help and the help of our community. So while we've been able to sustain ourselves with some grants and contracts over the last few years, we've found it more and more difficult to be awarded grants, despite our work being just as necessary, if not more necessary than ever. So we're turning to our community to ask for help, whether you can donate any amount to us directly one time or monthly. If you are able or willing to host a fundraiser for us, we've had a couple people in the past year graciously host fundraisers for us on their birthday. Or if you have connections to funders that you're willing to put us in touch with, or if you can just share with people in your life that we're accepting donations and share our work. We'd sincerely appreciate any support that you're able to provide as we continue to work to advance research and advocate for people with long COVID and associated conditions. So I'll also put a link to donate in the chat. And then, as always, you can email us anytime at team@patientledresearch.com. We really appreciate you for attending this webinar. We're so grateful to our community, and a huge thank you to the over 60 members of our PLRC team who make all this work happen and who have created the incredible PLRC community. So now I'm going to turn it over to Lucia to get us started on the Q&A. Lucia, you are muted. Can you unmute? Thank you.
Thank you. Thanks, Lisa. My name is Lucia Santos. I'm a member of PLRC. I've been sick with long COVID and ME/CFS since March of 2020. I have long curly hair, pale skin, and I'm wearing a maroon and white sweater. Thanks so much to those of you who were able to provide your questions in the Q&A. We'll get to as many as time allows. Let's start with Elizabeth, who asks, how do you expect the incoming presidential administration to affect your ability to get funding? What other impacts do you think it might have on your work? Lisa?
Sure, yeah, I can take that one. Thank you for the question. To be honest, it's a little unclear how the next administration is going to impact our work. And I think it does show just why organizations like ours are so important in order to help organize the community, in order to really push forward for, the patient lived experience. I think there's some areas of advocacy that we know are going to be particularly difficult, like especially prevention side of long COVID. Vaccinations are at risk. Any type of mitigations were already at risk in the last administration. That's probably going to be even worse moving forward. But then the incoming administration has also shared that they're dedicated to solving chronic illness. So, it's unclear what that looks like. I think a lot of the focus should also turn to like local and state work and seeing what we can get done on a more local level. And then for federal stuff, we'll kind of need to be nimble and just adjust as we see kind of what we're dealing with. So TBD in a lot of ways, but I know that the community will need to band together and really fight this fight, because it might be a tough 4 years.
Thank you, Lisa. We also have a question from Nita. If we have responded to the PLRC form to get involved twice and not heard back yet, will we get an update? Gina, excuse me. I think you'd like to speak to that.
Yeah, and also there's a similar question. What's the best way to get involved, as a patient with a research background? So I think Lisa noted that in her section where we talked about accepting volunteers, and we have a volunteer form. And so that's the best way to let us know. And we accept and onboard volunteers on a variable basis. It's usually based on our capacities to onboard folks, and because we want to make sure if we bring people on that we have a specific project in mind to keep them engaged, because we've had different experiences as we brought on volunteers. We also are looking to improve our volunteer system a bit, as I mentioned in my section. And so as we improve that and we work on that, we'll have hopefully a better ability to onboard folks a bit faster.
Thanks, Gina. We have a question from Bridget as well. Hi, I'm a huge fan of the patient-generated hypothesis journal and have a few ideas for it myself. Can anyone clarify what's going on with funding and other resources for that? I noticed over a year gap between the first issue in spring 2023 and the second in summer 2024. What is currently slowing this down? Is there a lack of patient ideas, funding? What would be needed for this to be a twice annual or even quarterly publication?
Lisa, I can take that. Yeah, definitely. Thanks for that question. I'm so happy that you have an idea. And no, it's not a shortage of ideas. There's plenty of patient hypotheses out there. It really is a shortage of funding and then capacity. So we initially were funded to do the patient-generated hypotheses journal by Balby, and we had 2 issues that we were going to do. So we completed that, and now we just don't have the funding to continue that. So, I think that would be, if we were able to get the funding to continue doing that work, we could explore that. It's basically the way we set it up is having a panel of patients who help choose the hypotheses and who help edit and research what's submitted. And then we then put it into the journal issue and format it and publish it. So still potential for future issues, but unfortunately, until we get additional funding for that, that's on pause, and we just have the 2 issues out.
Thank you, Lisa. We also have a question from Darren. Is there a resource where we can view the status of those trials, statuses, approvals, etc. Lisa, I think that's
I think that's related to the patient-led research fund. And there isn't that available now. I love that idea though. And maybe in the new year, we can work on putting together that type of resource. I think that would be great.
great. Thank you, Lisa. We have another question. What do you advise for those suffering from long COVID, but who either don't have supportive or knowledge in long COVID with their medical care team or do not have medical coverage at all? Hannah, can you speak to that?
I can answer that one. Yeah, I think it's very hard, and so many patients are still in the position where their primary care provider just does not understand the current research about long COVID. You know, these are people who didn't obviously learn about long COVID in med school and don't necessarily take the time to stay updated. We've seen some success when patients bring research papers into their providers, especially reviews of research. We often recommend the 2023 review we had mentioned earlier, or others reviews. There was also an excellent one put out by the UCSF team, Peluso and all, earlier this year as well. You know, sometimes it's just seeing the actual research and getting up to speed that makes a provider kind of, you know, understand what treatments are available, etc. And if they don't, you know, it may be just time to see another doctor. But also for those who don't have medical coverage, you know, there are some over-the-counter treatments patients are trialing. I think being part of patient support groups can kind of communicate which things like nattokinase and others are being trialed. There's over-the-counter or non-medication treatments like compression garments and salt tablets if you have POTS or dysautonomia, etc. But unfortunately, there's still a urgent need for vastly more sufficient medical provider education and coverage.
Thanks very much, Hannah. We have a question from George B. Do you mainly use quantitative statistical methods, or could any qualitative research feature? Gina, can you speak to that?
Yeah, I can speak to that. Yeah, I mean, we have, and you know, we've covered some of the qualitative research that we've conducted thus far. And even in our first paper that we had put out in 2020, you know, we had included some qualitative research into that one. So yeah, we have been conducting, and we still conduct qualitative research. So our the Brazil project featured qualitative research. The return to work paper was qualitative research as well. The India one will have some qualitative research. And so yeah, we are definitely doing that in addition to quantitative. We do both. And again, you know, I think one thing I wanted to mention is our work is directly related to whoever's in our, you know, it's participatory in nature, whoever's in our team and has the skill set and is, you know, excited about an idea. You know, we typically will, you know, go behind that. So, yeah.
Thanks, Gina. We have another question. Your educational efforts for doctors are commendable. I feel that there is an ongoing need for long COVID education of clinicians, both primary care and specialists. Is there going to be further work in this area? This seems to be a good one to take.
Yeah, I can insert that. Yes, we have lots of ideas to continue doing this work, including just trying to influence the medical curriculum itself, or even like going back earlier on and trying to influence, you know, science education per se, because just infection-associated chronic conditions in general are not studied. So we have been in conversations with partners and allies on how to continue this work. We need funding for it as well. And I also want to add that in the Brazil project, we do a component of medical education as well. And we try to influence that through the medical healthcare system by including like where the providers should get training. So we are thinking of like multiple ways that we can influence medical education.
Thank you, Leticia. We have a question from Uma. When can we expect the research paper out on long COVID survey from India? I'm assuming she's referring to our LMIC project.
Yeah, I can speak to that. That is coming out very soon, either this month, if we are, are able to stick to the deadline that we set for ourselves, or early next year. We are very, very close. It's more putting the final touches on it.
Thanks so much, Gina. There's a question in the chat with regard to what are our priorities or goals for the next 6 to 12 months.
Yeah, and so, oh, go ahead, Hannah.
I think either of us could answer. I definitely think that everything we mentioned earlier are kind of the areas where we're focusing on. I would say from an excitement standpoint, I know that it's hard for all of us who have been living with this for so long to feel excited and hopeful about the future, but at least from my personal perspective, I feel like this was kind of the best year for long COVID research yet. There are amazing teams out there like PolyBio and UCSF and so many others who are doing really incredible long COVID research. And I think that we're very close to starting to find biomarkers and other diagnostic tests, and more importantly, starting to see the results of some pretty incredible clinical trials. And I am really hopeful that both of those things will increase, and at least from my perspective, I'm personally excited to start, boosting those from PLRC.
A bit in that same vein, there are people with ME/CFS who have been ill for decades. And so Pam asks, how do we incorporate the vast institutional knowledge from ME/CFS patients medically, politically, historically?
I can also take that one.
Thank you.
Yeah, we've worked very closely with a lot of ME/CFS organizations and researchers, and many of us have ME/CFS from COVID. I think we made a priority very early on to learn from other conditions that are so similar to long COVID, because similarly, there has been excellent research done in those fields. For instance, we started trying to ask people to look at T-cell exhaustion and natural killer cell dysfunction and cerebral blood flow abnormalities, because those were found in ME/CFS and dysautonomia years and years ago. And of course, those were all found in long COVID as well. It doesn't make sense to start completely from scratch. The history of infection onset illnesses is hundreds and hundreds of years old. And there is research out there, and it's vital also just from a personal level to bring everyone who has been suffering from years into kind of the attention that long COVID has got, and hopefully that everything that comes for long COVID will be able to help those conditions as well.
Thanks so much, Hannah. We have another question from an anonymous attendee. Does PLRC consider potential crossover of long COVID and the COVID vaccine injuries? Many people in the patient community cannot differentiate between post-COVID symptoms and post-vaccine symptoms. Is there anyone that would like to address that?
Sure. Yeah, we've been advocating for inclusion of vaccine injuries, especially it was included in the Long COVID Research Moonshot Act, which we definitely support, and we do see a lot of overlaps. There's a lot of POTS that is sparked after both vaccine and after COVID infection. So we are definitely supportive of researching vaccine injury.
Great, thank you so much, Lisa. We have reached the end of our allotted time for questions. Thank you so much for your engagement and for the time you've spent with us. And I will send it back to Lisa.
Wonderful. Thank you, Lucia. As a reminder, we will send out the recording and the slides of this webinar in the coming days, as well as our job postings and our link to donate. Please share the job postings with your network if you are able to, or know someone who would be a good fit. And thank you again just so much for attending. We know all too well the cost that comes with exertion, and so we're grateful that you spent your spoons with us today. Sending you all solidarity, and hope you have a good rest of your day. Bye, everyone.
Bye.
Bye-bye, thank you.
Thank you.